So it's a pleasure for me to introduce our speaker for this afternoon. Dr. Katherine Kosiv is Assistant Professor of Pediatrics at the Yale School of Medicine. I first found out about Dr. Kosiv when she published what I consider to be a seminal paper, which I'm guessing she'll talk a little bit about, on heart surgery in trisomy 18 and 13 that was published in Pediatrics a few years ago. They worked with the Pediatric Health Information Database and produced what I think was a very seminal work. I then became reacquainted with her at the Fetal Heart Society when we both were on a panel last February. And then Katya published a paper in the American Journal of Medical Genetics, which was on a model of prediction in trisomy 18 and 13, which I myself have been quite enamored with. But that aside, let me introduce Katya as our speaker this afternoon. Thank you for agreeing to do this.
Thank you. Thank you so much from the SOFT organization and Dr. Carey for inviting me to speak and present on the topic of congenital heart surgery in trisomy 13 and 18. I have to say, the evolution of care in this population has been, quite dramatic. And it's such a pleasure to be a part of a community that remains so curious and is inspired by its patients. And if anybody's curious, that is the Yale Medical School behind me. So let's get started. So I guess first I have to just say I have no financial disclosures or conflicts of interest to report. So my goals for today's presentation are to discuss the improvement in trisomy 13 and 18 survival and use research to show how congenital heart surgery has played a role in this shift. I want us to consider some of the issues and conundrums relating to congenital heart surgery in trisomy 13 and 18 and introduce a potential model to assist in decision-making. Lastly, I want to end with a look at what things could and should look like in the future. So trisomy 18 and 13 are the second and third most common chromosomal trisomies. About 80% of trisomy 13 and 90% of trisomy 18 patients will have some form of congenital heart disease. Septal defects and PDAs are the most common, but complex heart disease is also present. So here we have a representation of the defects seen in trisomy 13 and 18, and these were taken from our study in 2017. And you can see that the big circles are, the more common ones. We have ASD, VSD, PDA, but we can also see that we have got double outlet right ventricle, pulmonary stenosis, coarctation, and smaller, representation, transposition to great arteries, tetralogy of Fallot, AV canal defects, truncus arteriosus, and hypoplastic left heart syndrome. So overall, it's a potpourri of cardiac findings. Most recent large-scale estimate of survival in trisomy 13 and 18 around the world was published by Goel et al. In 2019. So a review of 20 registries, and this is international, revealed a median mortality of 52% within the first week of life for trisomy 13 and 58% for trisomy 18, with nearly half of all deaths occurring on the first day of life. 16 registries recorded data to 1 year of life, and estimates of mortality were 13% for trisomy 13 and 12% for trisomy 18. 11 registries recorded data out to 5 years, and estimates of mortality were 7% for trisomy 13 and 8% for trisomy 18. In my practice, I often provide a conservative mortality estimate of about 50% within the first week and 10% within the first year of life. However, long-term survival depends on medical and surgical interventions. So in 2016, Nelson et al. Published a study in JAMA assessing the prevalence of medical and surgical intervention in trisomy 13 and 18 in Ontario, Canada. This study showed that long-term survival was higher than expected. 71% of patients with trisomy 13 and 69% of patients with trisomy 18 survived to 1 year following their first surgery. Furthermore, median survival was greater than 1 year in all surgical cases, except for eye surgery in trisomy 13 and cardiac surgery in trisomy 18. So if we look at this graph from that study, you can see that here, here's the 1 year mark, and we're right in that 70%, and then this goes out to 11 years, and we're right at around 45% about. So this study gave me pause. I had encountered a few patients with trisomy 18 in my clinical training by that time, none of which had undergone any surgical intervention. The expectation was that children born with trisomy 13 and 18 would likely die before a surgical intervention would prove beneficial. As physicians, we are taught first do no harm, but here was data suggesting we might curtail survival by withholding intervention. So this led me to wonder, can children with trisomy 13 and 18 experience improved survival with cardiac surgery? So in order to capture a large sample size, my co-researchers and I utilized the Pediatric Health Information System database, or FIS for short. So FIS is a large database of children's hospitals in the Child Health Corporation of America, a children's hospital consortium. We included patients less than or equal to 14 days of age at the time of admission and an ICD-9 code for congenital heart disease in either trisomy 13 or trisomy 18. We looked at repeat hospitalizations to conduct Kaplan-Meier analysis for survival. And in total, we identified 1,668 patients. There were 1,020 subjects in the trisomy 18 group and 648 subjects in the trisomy 13 group. 91% of the trisomy 18 patients and 86% of the trisomy 13 patients had congenital heart disease, similar to what had been presented in the literature. In both, congenital heart surgery was performed in 7% of patients with congenital heart disease. Overall, 131 operations were performed over 12 years. The most significant finding was that in-hospital mortality is significantly lower in subjects who have had congenital heart surgery. So we look here, it's 30% versus 55 and 16% versus 44. We found other interesting differences. Including that the congenital heart surgery groups had a larger birth weight, seen here, had obviously a longer length of stay, probably related to their surgeries, and then more of them required mechanical ventilation. Multivariable analysis revealed a 64% reduction in in-hospital mortality in the trisomy 13 group and a 45% reduction in the trisomy 18 group. In-hospital mortality was also decreased in infants with a higher weight, female gender, and older age at admission. Interestingly, case center volume did not impact in-hospital survival. To assess whether the survival advantage persisted following discharge, we assessed survival using readmissions. Because the FIS database can only capture in-hospital problems. So in order to kind of see things longitudinally, we had to look at readmissions. This Kaplan-Meier curve demonstrates that congenital heart surgery, which is the solid black line, was associated with a marked increase in freedom from in-hospital mortality for both trisomy 13 and 18, and that's out to 2 years. This graph is also illustrative of the high in-hospital mortality rate in the first few days of life in the non-congenital heart surgery group, and you can see that here. Additionally, we wondered if other interventions could have impacted survival. We noticed that gastrostomy tubes were more common in patients having heart surgery. So, 22% versus 8% in trisomy 13 and 25% versus 16% in trisomy 18. We also wondered if mechanical ventilation played a role, since more patients undergoing mechanical ventilation also had heart surgery. Overall, the median number of ventilator days was low, both pre and post-operatively in the congenital heart surgery group. But we didn't know, kind of the impact of that. We also considered if tracheostomy affected survival, but found that the number of tracheostomies was very low. There were no tracheostomies in the trisomy 13 group and only 6 in the trisomy 18 groups. You have to understand my surprise at this point, because because of the experience, I guess, of mine until that point in healthcare. And my hypothesis going into this project was that congenital heart surgery did not confer a survival advantage. Yet our data supported the idea that cardiac intervention affected survival. Additionally, many smaller scale studies from the United States and Japan have also linked cardiac intervention with improved survival. The findings regarding survival may have also led to an increase in the number of operations performed. Here is a look at 3 retrospective studies performed over 35 years. As you can see, the number of operations performed is growing. All 3 retrospective studies used different databases or registries. Peterson et al., which was published in the Annals of Thoracic Surgery, used the Pediatric Cardiac Consortium registry and noted 95 operations from 1982 to 2008. So that's a 27-year period. Our study reported on 131 operations from 2004 to 2015. So more operations, shorter period, 12 years. Most recently, Cooper et al. Presented data from the Society for Thoracic Surgeons Congenital Heart Disease database, Congenital Heart Surgery database, and reported 343 surgeries from 2010 to 2017, so 8 years. So more surgeries, shorter time span. The last and most recent study by Cooper et al. Found that 70% of centers performed at least 1 operation during the study period, and 30% of centers performed 5 or more. Over the study period, the number of cases rose from around 30% to about 45%. So looking at this graph from their study, where the bars represent the number of cases and the lines represent mortality, if we focus just on the bars, there has been a steady increase in case volume from 2011 to 2016, and that's especially notable when we look at these blue bars for trisomy 18. They also found that overall survival following heart surgery was between 85 to 89%, compared to 97% in non-syndromic patients. And post-operative complications occurred in slightly over half, compared to 36% for all patients. So a slightly lower survival and slightly more complications. Prior cardiac surgery occurred between 16 and 21%, and mechanical ventilation was noted in about 22 to 33% preoperatively. About 23 to 25% had a G-tube preoperatively, and non-cardiac anatomic abnormalities were noted in almost half of the trisomy 18 patients and about 20% of the trisomy 13 patients who had had heart surgery. When analyzing the types of operations performed by complexity, which is called STAT score, where 1 represents lowest risk and 5 highest risk, you can see that STAT 4 and 5 cases are represented here. And those would include Norwood, Glenn, and Fontan procedures for single ventricle palliation. Survival did vary by STAT category. For trisomy 13, only STAT 2 cases conferred a slightly higher mortality when compared to all SDS cases. However, for trisomy 18, mortality was 3 times higher in all STAT categories. For both trisomy 13 and 18, Preoperative mechanical ventilation was associated with in-hospital mortality. And you can see that here with the odds ratio. However, gastrostomy tube placement and prior heart surgery were associated with survival in trisomy 18. So thus far, we are learning that cardiac and non-cardiac intervention impacts survival. I haven't really focused on the non-cardiac, but from that Nelson paper, it definitely impacted survival. But mortality is still significantly elevated, especially in the first week or two of life. So my questions are, what role do additional comorbidities play? We can see from the Cooper paper that non-cardiac abnormalities were present in were present in only 20% of the trisomy 13 patient. Is it possible that the patients selected for surgery have fewer comorbidities, or are they selected because they have fewer comorbidities? What is the impact of mechanical ventilation? The Cooper study reports that preoperative mechanical ventilation was negatively associated with postoperative survival. So with still significant differences in mortality comparing trisomy 13 and 18 patients after congenital heart surgery, how do we decide which patients benefit most from congenital heart surgery? So our next step was really to focus our attention on understanding the difference between survivors and non-survivors with trisomy 13, 18 and develop a prediction model. So to do this, we had to analyze all trisomy 13 and 18 patients with congenital heart disease and categorize all their diagnoses and procedures. We grouped diagnoses into organ categories, such as abdominal wall defects, ear, nose, and throat, and endocrine disorders, as an example. So for abdominal wall defects, we included things like gastroschisis and phalloceal. We also made categories for premature birth weight, birth injuries, and perinatal disease. We included specific procedures like mechanical ventilation, ECMO, and gastrostomy tube, because we thought those impacted survival. And if anyone is interested, a list of all the diagnoses and categories is available for review as an addendum in the addendum to the paper. So in total, we had 38 diagnostic and 12 procedural categories, which made their way into the model. So our primary outcome was survival to 6 months of age. This is the timeframe used by the STS, so the Society for Thoracic Surgeons, to assess operative mortality. To avoid inflating our survival estimates, we assumed that only subjects with an admission beyond 6 months would be considered alive. The model comprised 48 predictors and included 36 diagnostic group variables, 8 procedural group variables, sex, length of stay, birth weight, and gestational age. And I've highlighted in red the ones, the categories that actually have hazard ratios associated with them. So these are the diagnostic group variables, and then these would be the procedural group variables. So we tested our prediction model using linked data from the California Perinatal Quality Care Collaborative, which is abbreviated CPQCC, and the California Office of Statewide Health Planning and Development, also called OSHPD. ROC curve revealed a relatively good model based on the C statistic of 0.76, and this is out to 60 days. In total, we identified 1,761 subjects with an admission to a FIS hospital less than or equal to 6 months of age, with 679 in the trisomy 13 group and 1,082 in the trisomy 18 group. Compared to the Cooper study, gastrostomy tubes were performed a little bit less frequently, 12% in trisomy 13 versus 25% in their study, and 20% in the trisomy 18 group versus 23. The incidence of congenital heart disease was between 80 and 90%, again, keeping in line with previous studies. Mechanical ventilation was common. You see it's about half of all patients. And bacterial infections were diagnosed in about a quarter to a third of patients. There were various predictors within the model, and those predictors were assigned an importance value. So for example, ventilation, length of stay, and gastrostomy status had high importance values and therefore are important predictors in the model. And I've placed hearts next to other important variables that I'm going to talk a little bit about. You can see that cardiac surgery, so these are hazard ratios, and you can see on this side we are protective and on this side we're hazardous. So you can see that cardiac surgery was associated with a 53% improvement in survival to 6 months. Gastrostomy tube placement of 57% improvement in survival, and total parenteral nutrition of 47% improvement. Mechanical ventilation, on the other hand, was the most significant predictor of mortality. I want to return to this issue in a little bit. We also wanted to assess the impact of procedures that vary with time, so such as cardiac surgery, gastrostomy, and mechanical ventilation. Interestingly, so this is the cardiac surgery one. Interestingly, the survival advantage afforded by cardiac surgery does not vary with time. This is incredibly important because even though some cardiac lesions may not be critical at birth, over time, they may result in complications such as pulmonary hypertension and heart failure. Though this model is unable to predict optimal timing for performing heart surgery, it does not support the notion of delaying surgery based on a diagnosis of trisomy 13 and 18 alone. The next one is gastrostomy tube placement. And you can see it kind of has a similar look to the previous one, where the orange represents placement of a G-tube. But here with mechanical ventilation, the blue and the orange lines are inverted, and it's associated with worse survival probability. So this required some additional thinking. When we looked back at median survival, we noted that non-survivors lived for only 1 to 2 weeks. We thought that perhaps mechanical ventilation was being inappropriately linked to the high percentage of deaths within the first week or 2 of life. So going back to the Goal et al. Study, almost 50% of infants with trisomy 13 and 18 die within the first week of life. So to remove the impact of possibly fetal interventions, we revised our prediction model so as to exclude procedures performed on the day of death. This revised model had a C statistic of 0.75, which was comparable to the initial model C statistic of 0.76. We then trained the revised model using this new definition for procedure groups, and lo and behold, mechanical ventilation becomes protective when you exclude procedures performed on the day of death. We also wanted to see the impact of the type of congenital heart lesion and utilize the RACS scoring system. RACS stands for Risk Adjustment for Congenital Heart Surgery and is used to address the difference in mortality following congenital heart surgery by lesion. Additionally, we considered the effects of pulmonary hypertension, heart failure, and arrhythmia to see if certain cardiac comorbidities played a predictive role, and only RACS level 3 lesions were associated with a 22% increase in mortality. So that would be, so RACS 3 would represent mitral valve, tricuspid valve surgeries, AV canal operations, transposition of the great arteries, double outlet right ventricle. Those are the ones that come to mind. So to summarize the model's findings, congenital heart surgery improves overall survival in trisomy 13-18, and the effect is present from birth. Gastrostomy placement and nutrition are important predictive variables and should be closely evaluated in patients who may need heart surgery. The relationship between mechanical ventilation and survival is unclear and requires further study of the respiratory dynamics and high mortality at birth in trisomy 13 and 18. The other predictive variables in the study require additional testing to assess their accuracy. Hopefully, this tool can be converted into a user-friendly format for widespread clinical application. So I realized that I titled this procedure an update and future directions. However, I think the future is kind of here in the sense that you can see that many centers are providing surgery, and some centers provide a personalized and comprehensive care plan for children with trisomy 13 and 18. And I think I'm less of an expert to speak on this than our previous panelists, Dr. Starr and Dr. Burge, who have published their experience at the Interdisciplinary Trisomy Translational Program. And I would draw your attention to their review, which was an excellent presentation of the literature grounded by their work. But I cannot conclude this presentation without a discussion of how cardiac care for children with trisomy 13 and 18 can look like. We know that these children have additional medical and developmental problems which require attention. However, a myopic viewpoint of each problem can stymie a child's progress. Therefore, a multidisciplinary approach focusing on shared decision-making is likely the best way to move forward. I have seen how well this works as a member of our fetal care center. Coordination of care, knowledge sharing, and communication is vital in taking care of complex patients. Families need to know that we are partners in the care of their child. In conclusion, I believe congenital heart surgery positively impacts survival and has played an important role in the overall paradigm shift regarding the care of trisomy 13 and 18 patients. I hope that our prediction model can provide insight and help navigate decision-making. I still have unanswered questions, mostly related to the ventilatory needs of this population and why there is such a high mortality rate in the first 2 weeks of life. But I think these studies highlight that the cardiac care of patients with trisomy 13 and 18 is changing and should take place in a multidisciplinary care model. I just want to conclude with just a thank you to all the people who have been involved in this. Most significantly, I want to thank my mentor, Tom Collins, who's now at Stanford. We were both at UAMS when I was doing my fellowship, and that's in Arkansas, for those of you who don't know. And I think the question was first born there. And we've had wonderful statisticians who've also moved on. Jin Long from Stanford in particular was instrumental in creating this model and helping us to translate it. And Dr. Lee at Stanford helped us to validate it with using OSHPD and the CPQCC. So I just want to thank those individuals. Such a privilege to work with these people. And so I just want to thank everybody for listening, and I'm happy to take any questions. Hopefully I didn't go too quickly, but this is a picture of the Mill River here in Connecticut, and this was during the pandemic. So we did get some beauty amidst all the craziness and the difficulty. So thank you.
Thank you. And Dr. Carey, I just wanted to let everybody know that if you have any questions, feel free to ask those in the Q&A, and Dr. Carey will direct those to Dr. Kosiv.
So Katya, I'll take the chair's prerogative. First of all, the talk that you just gave for I think for Terry, maybe Kelly as well, some other listeners, I couldn't even have envisioned the language around this talk as recently as 10 years ago. So thank you for just crystallizing where the work has come originally from Japan and where we are. So I appreciate that, want to acknowledge it. But I think that issue you identified about such early mortality in the first week or so of life is really important because, as you pointed out in the Nelson work, in the Nelson study from Ontario, those are the same median survival, the same frequency of those that survived the first week as were present in the 10 epidemiologic studies that were population-based in different parts of the world between 1985 and up to that study in 2016. So there has to be something different about this first week or so of life. And it could be, we know that only a few percent have diaphragmatic hernia. We know only a few percent have a tracheoesophageal fistula. We know only a few percent have something like hypoplastic left heart that might lead to more early demise. But I couldn't agree with you more that I don't want to think there's exactly some sort of bimodal curve. I don't have enough sophistication, but there has to be something about that. And I couldn't agree more about study. But my question is, and I'm not sure that I have to see the context in which you said it, but you made a comment when you were still talking about your paper in Pediatrics from that data, from the FIS data, about decisions regarding early surgery. Do you remember about timing on surgery?
I think so. Well, one thing I did mention is, so this is in the model, but we tried to understand, like at what time. So I think I'm just going to show this picture. Is this the one?
Yes.
Yeah. So this was in the model. So, again, the idea was how do we guide, clinicians, what's the best time to do things? And so, we thought it would end up being something like along the lines of at 1 month or at 2 months, where you would start to see that, this curve past this curve. And that's just not the case, so there was this kind of concept or this idea that, well, it's, heart surgery could be offered in the survivors. And I think that in the sense that maybe beyond 1 or 2 weeks, okay, I can understand survivorship, but really beyond that, I don't think there's much of a difference to weight. And so that's what this curve showed, that the timing of surgery, that the benefit provided did not like start at any particular time point. It basically started from time 0 onward.
Right. This is what I wanted you to help clarify. So again, like just getting past the first few weeks of life or whatever those variables are, even maybe pulmonary hyperplasia, central apnea, but getting past that, after that time period, wouldn't weight enter into the picture? Because isn't a baby's weight a factor in survival? So that one argument, even in that early period, to weight might be
right.
Weight meaning WAIT versus the weight of the baby. So
yeah. No, I think that's a really good point, because oftentimes, so I'm just thinking about scenarios, where a child may be born and weigh, maybe a little bit on the small side. And so we may say, well, let's try to, beef that baby up, feed her plenty of, or him or her plenty of calories, we'll work on, like we're talking about gastrostomy tube, TPN, and we know that that's also beneficial. And so I guess the interplay there, there probably is some effect. I just, to parse it out, I think I'm not sure the best way to parse it out, but I do see what you're saying. And I do think that also, based on like what we found, makes sense. I don't know if there could be maybe a weight cutoff, let's say, where at this point we see, the hazard ratio go up much more. I think when we talk about translating the model into something clinically relevant, that's where those things can become, I think, maybe helpful, where, we're sort of using like cutoff values. So that might be something very good for when this is, translated into like a more clinically or something more clinically useful.
In your long list of variables where you had the little bars that went across, mm-hmm. Then you ended up coming up with what the best predictors were. What was percentile weight for age a factor, or was that entered into the equation?
Yeah, so we just used, I'm just going to go back here.
Yeah.
So we used birth weight as our, so we used birth weight as our predictor because, the thought being, I think this is the revised, no, this is the original one. So we use birth weight. So I think birth weight, it's going to, you can see how it can be impactful, right? Because larger babies who are larger at birth, we've already shown that there's a survival advantage there. So I think that concept, weight for age, would be something really interesting to look at. I didn't think of that.
Well, I was only thinking because yesterday, Dr. Burgess' talk, she actually mentioned where weight is a factor, but she wasn't talking about trisomy 18 and 13. And I was actually thinking of your model. She was talking about all children. And, and so and she was nicely applying it to trisomy. But so that's what made me, hearing her talk the day before your talk, just thinking about those variables. But again, I want to give other people a chance to ask questions, but I think it speaks for, thinking of ways to apply your model so it'll be helpful for clinicians, maybe like you said, after the first 2 weeks.
Yeah, I think you have to, that huge drop off, it's just so, dramatic, that I would definitely at least wait, that period. And I think that's reasonable considering what other things we can do, non-surgical ways to kind of maintain patency of the duct and things like that. So we could support people medically, we can support patients medically, and give it some time.
Right. So I don't see any questions in the box. Did anyone have their hand raised? Oh, here's a question from Chris. Mm-hmm. Is the high mortality in the first 2 weeks related to interventions that were not done?
Mm-hmm. I think that's a good question. And I don't have a perfect answer because that's not something I've looked at closely. It's kind of like what I'd like to do. I think that it could possibly, so when we look at that goal study, and I don't know if I'm pronouncing it, maybe it's Goel, but,
right.
The highest number is literally on day of life 1. And it could be, secondary to, the not doing certain neonatal resuscitations, possibly. So I think that would require, some examination. The problem with the FIS database is that you don't get that granularity where you can tell, what was the decision making, beyond, in terms of, for example, for our interest, it was congenital heart surgery. So could it be that, that maybe certain interventions were withheld? It's possible, where resuscitation, including mechanical ventilation, was withheld, and that's why there was demise. But I think it's a really good question and probably something that, we should look at more closely.
So Dr. Kosiv and I have been discussing with a number of other people about the possibility of doing a longitudinal study prospectively looking at all of these issues. And just as we've been talking about orchestrating this study with the Neonatal Research Network, a paper appeared that was a paper from a group of children's hospitals, NICUs, and newborn intensive care, and it didn't. And the majority of patients in this study, it was published in Journal of Perinatology, and the first author was Achira, and I apologize to her if I am not saying that beautiful Eastern Asian name properly, or South Asian name properly. But either way, what they clearly said, and that's why I like your word granularity, is that they weren't able to distinguish those that chose pure comfort care without interventions, whether they were patients that were very stable and just didn't need very much help, might have only been in the nursery for a few weeks or something of that sort, but had no G-tube, no ventilation, may had something done, versus patients who were truly taking a path of no intervention whatsoever. So that in fact, it was an approach where, well, I say no intervention, I mean technological intervention. Obviously, good palliative care involves good hands-on care, and there's definitely intervention, but it wouldn't be someone was going to have respiratory difficulties, then one would consider putting the baby on a tube and so on. So they made the point that they couldn't distinguish those groups. I would hope if we were able to do a longitudinal study that we might be able to distinguish what the goals were of families from the beginning as to those who made a choice of no intervention, not necessarily being able to distinguish someone who might not have been able to have intervention. Anyway, I don't think I said that clearly at the end, but Dr. Maureen Boshin has a question. Dr. Kosiv, were there significant sex differences in survival rates?
Thank you. Yeah, Maureen, for your question. So in the first paper, we did see a difference with female gender being associated with improved survival. We did not see that in the model. At least from my reading of the literature, it always appears that the female gender is like overrepresented, especially in trisomy 18. And so in the first paper, we sort of made that conclusion, like, is there this sex difference? We just didn't find it in the model. This might be better answered by Dr. Carey from the genetic standpoint, but it's hard for me to understand the physiologic or how that could be connected, I guess, that there's a sex advantage, but I think that could be, a deficiency in my knowledge.
We know that even at birth, it's almost 3-to-1 girls to boys. We know that in fetal demises, from studies that have been done where you have an amnio and then you follow the pregnancy outcome, that a baby dies prior to birth, stillborn. We know that more often males are represented in that fetal death group. We also know that in the population studies and the ones with the largest numbers, which includes Rasmussen's CDC study, and then more recently the Texas study where there were 300 children, that at 1 year survival, girls survive better than boys. So we don't know exactly what goes into that biologically either. And that's why I'm interested again, I think, and thanks, Maureen, for that question. But I think as you try to work in implementing your model, it'll be important to build that question in, because certainly in the test of time, looks as if survival is better in females than males. Now, in the individual situation, in the newborn nursery, in care conferences and such, I personally have not felt that it was appropriate to overstate in a boy that should factor in, because I felt that we should be taking each individual on their own. And thus, people have brought that up before, but I guess my position has been in that individual case, we don't really understand it biologically, so we shouldn't be using male sex, male gender, to decide that we're going to withdraw support versus not withdraw support. At least that's been my stance, my approach to that.
Yeah.
So again, I think it'll be really cool if we're able to take your model and actually implement it, and to help people in terms of these issues. And we'll pick a 2-week-old in terms of where to go from there. So I think we've identified this theme of the first week or so. We'll just say the first 2 weeks as being so important. And even in these studies of better survival, like Ontario, there must be, I would think, a group of infants who either have the central apnea, who we can tell early on from ventilators that they're going to have a hard time making it at 11 days of life, 10 days of age, whatever. Mm-hmm. Not going to pick a time necessarily, but I think those early that early issue, I think, is really important, and it might be as you ideally could apply your model, again, trying to figure out how that fits in.
Yeah, I think that, even from doing this, the question of ventilation just to me seems like this major conundrum, because, it's always linked, with poor outcomes, but yet at the same time, I don't think we understand it. Like, I think the making that, causal linkage is not really doing it justice. So yeah, it would be wonderful if we could drill down, to what's going on there. And I think I'd hope that would, to also give us better understanding, in terms of care,
Right. Because as you pointed out, this is a very nuanced issue. That is, the Cooper study says those who went to surgery on a ventilator had poorer survival. Yet when you factored in, and I can't say I know about the day of death procedure, I could word it, but not sure I
right. So we took
around it.
Yeah, we took all. So the way that was done was by understanding the death, the date of the death, and then knowing, because all of these are codes that are coded, every day. And so if you take out all the codes, that or procedural codes performed on the day that a child died, you took that out, then all of a sudden it became protected. And so I think that what probably was happening there is a lot of children maybe got ventilated on day of life 1 and passed away, and so I think, again, it's trying to drill down to what's going on, right from the get-go. Yeah, exactly.
I think that's another key issue, another issue that, and that's why, again, not to be naive about this, but as you know, that's why this, and I think that the neonatologists at the 17 centers who heard the idea for a proposal were in favor of a proposal, because this is so complex. Mm-hmm. And it might be that it'll be harder for us to answer that by even a longitudinal study, but I think it's worth us trying to do it if they fund us. So right now, Dr. Kosiv and I and we're waiting to see whether or not the National Neonatal Network a neonatal research network funded by the NIH is interested, when we put in a full proposal, of actually really, as you say, drilling down. I'm going to use that word, drilling down into these issues to determine whether we can sort them out.
Thank you so much.
So really,
I don't want it to just end up being a discussion between you. I hope if there's anybody else has questions, I'm happy to try my best to answer them.
Well, we can also say that you were crystal clear. No, you were. So, but we're close to the end of the hour. Are there any other questions, comments? Please, we'd love anyone else jumping into this discussion. So I can see, maybe the audience can see why I invited this exciting investigator who has been thinking about these issues in a depth that I don't think we have been, because there was almost never, for such a long time, no one would even think about surgery. So now we have smart people trying to think about this in more depth, and it just does my heart well. So thank you, Dr. Kosiv.
Thank you, yeah.
For participating, and everyone, of course, our conversation with our two questioners, as well as you and I, is also as part of what will be retained on the talk. So welcome everyone to, once they're up online, to look at them again.
Thank you, Dr. Kosiv, and thank you, Dr. Carey. Dr. Kosiv, we really appreciate you sharing all this information with us. And like Dr. Carey mentioned, this will be on our website by next week. Do we have, well, we do have another question, Dr. Carey. Do you see that?
Let's see, I have to pull up the question little thing.
From Dr. Boshian.
Oh, yeah.
Yeah.
Would you read it, Kelly, please?
Yes.
My box for the questions has gone away, so.
Okay. It says, would doing gene expression arrays in males versus females or in survivors versus non-survivors be too wacky?
I'm going to leave it to you.
So I know Dr. Boshian very well, and I know her brilliance. It's interesting you asked that question, Maureen, because that idea of doing gene expression, not just for gender, was something that Janine Cody at University of Texas in San Antonio proposed about 10 years ago in a study that, and I was one of the co-investigators, a study that we were going to do we were going to compare certain expressions of genes in transcriptome patterns in children who were greater than 6 months of age, up to a year of age, and children who had passed away in the first few weeks of life. And of course, it'd be hard to sort out who got intervention, who didn't, and such. But that was the exact way in which Janine wanted to do that. And of course, you asked about it in gender. She was asking about it in other variables as well. So I don't think it's wacky. And I think there could be molecular aspects to this that we still have to think about.
Okay, it doesn't look like there's any more questions. We want to thank everybody that took their time to come and listen today. And we would like to, again, thank our presenter, Dr. Kosiv, for sharing all of her information with us.